Yeah, this segment has a few objectives. We'll start by just discussing just generally some of the opportunities and challenges with doing research based on Medicare utilization data. We'll talk about, some of the challenges and opportunities from the encounter data specifically. And then also we'll discuss some of the key differences between the encounter and fee-for-service data that are good to think about as you are designing your study. So just to start, I think that there are some key strengths from Medicare data. And some of this might seem kind of like simple facts, but actually they're quite important. So, the demographic data in the Medicare data is really very reliable and valid and validated. So, as an example, um, I'm working on a project right now that is following clinical trial participants in the years following the clinical trial, and there is some contact with the participants to collect information, but data information is missed in that in trying to survey people, and so information like date of death is in the Medicare data for the people who consented to these linkages, and it is allowing us to get a much better sense of sort of the kind of long-term health trajectory of these trial participants. So that's actually a really important piece of data. But the other demographic information is also quite important in Medicare data. Um, and the we really have excellent data with the caveats we discussed about the services used by Medicare enrollees in terms of dates of service, the types of services they used, who provided the care. So we can learn a lot about that information using Medicare data for Medicare Advantage or traditional Medicare. Um, for both sets of data types of Medicare data, a key strength is the ability to link the program data, the healthcare use data, to other data sources. So I mentioned the clinical trial data. So we've learned so much from linking the health measures and survey responses and assessments in the clinical trial I'm working with the Medicare data. I think it's a really powerful combination. And then there are other types of linkages that are important. The SEER Medicare data is a great example of, working with detailed information for cancer patients with the healthcare use. So a lot has been learned from that linkage. Another example I'm pretty familiar with is the linkage of assessment data with Medicare data. And in fact, actually, the assessment data, besides providing information about functional status for Medicare beneficiaries in nursing homes for the minimum data set and other settings for other data sources, it actually is another good source as sort of a gold standard for whether someone is in a skilled nursing facility that you can use to sort of compare to the encounter data for the Medicare Advantage folks. And then another really valuable linkage is like the Medicare current beneficiary survey. So, the linkage of a survey of Medicare beneficiaries with claims is really quite another powerful data source. And one example of this is just that, in the Medicare data, of course, we don't see information on, care that's provided by family caregivers. And so it's really hard to understand how like certain payment policies, like bundled payment or the growth of Medicare Advantage, like how has that affected the sort of burden of care on caregivers and, the MCBS is a great example of a data set that allows you to study that question. So we've talked about a few advantages and opportunities, but what are some limitations sort of both the fee-for-service and the encounter data? There are services we don't see in the Medicare data because it is either not covered or not paid for. So services that are not covered will not be paid for, and we won't see them in the prescription drug data or in the other counter or claims data. For example, treatments that aren't covered. Part D medications. We only see medications that are covered, included in formularies. And then the other issue is that there are certain services where we don't see utilization because the claims aren't submitted. So something like immunizations can be quite inexpensive, and people just pay for them out of pocket. Or another example are certain generic drugs, like you can receive a $30 a 30-day prescription for some generic medications for $4 at Walmart, or a $10 for a 90-day prescription. So when that type of transaction happens, we're not necessarily going to see it in Medicare data. Another tricky part of working with fee-for-service and encounter data is identifying different diagnoses. And there can be both underreporting or overreporting of clinical diagnoses. So one issue is certain conditions that are maybe not as acute, like might not be reported on claims data. And this is especially the case in traditional Medicare, where there's maybe less incentive to code some of these variables, but conditions like hypertension, depression, mild cognitive impairment, these diagnosis codes may just not be entered on a claim. And so that's a potential issue. Also, we don't see the dates of diagnosis in the claims data, but rather we see the dates of service, the date that a health service was provided and the diagnosis was recorded. So that's another kind of tricky thing to interpret sometimes. We see the care for a disease that was received, but it could be that someone had a health condition. For various access reasons, they did not get in to see a healthcare provider. And so we are not actually able to, that's just like missing data. Like they had the condition, they needed care, but because they didn't receive care, it's not observed in the data we're using. In order to really identify that people have certain conditions, you need to apply an algorithm that kind of searches goes through the different diagnosis fields in the claims or encounter data, and then flags that, yes, we've seen a few occurrences of a certain diagnosis code within a given period, so we're going to conclude that this person has this diagnosis. Of course, if we're working with the traditional Medicare data, the master beneficiary summary file has the chronic condition segment, and so the algorithm is applied for us, and we can just use those flags in our analysis. But it's more complicated for Medicare Advantage. At the moment, there is not a chronic condition segment using the encounter data. And so what you can do is apply the chronic condition segments algorithms to the encounter data, which is something that I've been working on a project recently, and that's actually quite doable, but it does certainly require some effort to apply those algorithms, and you do have to worry about upcoding. So especially for Medicare Advantage, there's this evidence that chart reviews are a way of sort of recording additional diagnoses to increase payment. And if you're really trying to make apples to apples comparisons of different Medicare beneficiaries, like those diagnoses may be, sort of problematic. And so it's there's definitely an argument for taking out the chart review diagnoses, but even with that, upcoding still may be a concern. So the diagnosis information in the encounter data can pose some challenges. Another issue is just, outside of the diagnoses that are on encounter data or in claims, we really lack other health information, especially sort of intermediate health outcomes. So measures of chronic disease management, such as BMI or hemoglobin A1C or blood pressure, like we don't have those data, or test results. And then there is sort of some behavioral information on smoking or alcohol use, but it's sort of underreported and maybe not optimal. So and this is always something that comes up when you're trying to do analysis with Medicare data. Like you just have these very extreme health outcomes like mortality, or maybe hospitalization for something like a stroke or a heart attack, but the sort of kind of less severe health outcome measures are difficult to obtain or impossible. There are some challenges about sort of code identifying procedures that have occurred. So in the inpatient data, this is coded using ICD-9 or ICD-10 codes. In the carrier or the durable medical equipment files, these are coded using HCPCS or CPT codes. And so, like generally, it's just tricky to construct a crosswalk of procedures between the ICD-9 or 10 and the CPT codes. All right. So those are some challenges that are common to fee-for-service and Medicare Advantage data. Let's talk about some similarities between the fee-for-service and encounter data. One thing that I think has been quite useful when I have sort of started working with analysts to work with the Medicare Advantage data is that the file structure for the fee-for-service and encounter data have, generally similar structures. So thinking about the carrier file and the outpatient file that we discussed in the previous segment, the overall structure is similar in the sense that you have a base claim file that includes sort of summarized information for the encounter, and then the line or revenue center file that has a line for each service. That general structure is in both types of data, and the variable names are also very similar. So I think that really eases the transition for someone who's worked with traditional Medicare data and wants to work with the Medicare Advantage data. That's really helpful. The ability to link data across all of the different Medicare files. So the Part D data, the institutional data, the professional data, the MBSF, the assessment data for post-acute care, all of that is the way that you work with that in traditional Medicare data is the same for encounter data, and it's quite well, it's not easy exactly, but quite doable. Another something that's in common between the two data sets that's really helpful is that you can really follow people over time. So one for me in my research, sometimes we have constructed episodes of care that start with a hospitalization, and then we look at where people came from prior to that hospitalization. Were they in a nursing home or were they out in the community? And then we sort of follow what happened to the person after they were discharged from the hospital. Did they receive inpatient rehab? Did they receive home health care? Were they in the community at different points? And that process is like very, very, very easy to implement in both Medicare Advantage and traditional Medicare data. Okay. So I think starting on some of the differences between Medicare Advantage and traditional Medicare, it's important to think about some of the challenges in the Medicare Advantage data in terms of thinking about resource use and costs and how to measure that. And the key challenge is that unlike the traditional Medicare claims data, the encounter data does not include information on payments. So we can see that a beneficiary received a certain health service, and we can see who provided them that service, but we're not able to see how much the Medicare Advantage plan paid the provider. And so this poses some challenges if you're trying to look at the effects, of a policy on healthcare use, or sorry, healthcare costs or healthcare spending. And so let's think a bit about like the different kinds of questions that we might want to look at in terms of resource use. So one question might be, how do costs or resource use differ between Medicare Advantage and fee-for-service Medicare enrollees? We might also want to compare costs or resource use between different types of Medicare Advantage plans. So, for example, between HMO plans versus PPO plans, which have, the HMO plans typically have more limited networks. The PPO plans have much more flexibility in terms of where enrollees receive care. And then finally, a third type of question you might want to ask is, how does Medicare's total spending on healthcare for fee-for-service enrollees differ from Medicare Advantage plan spending on healthcare for Medicare Advantage enrollees? So basically, we can sort of tackle questions 1 and 2 using the encounter data. But the third question is quite difficult for us to, and maybe impossible for us to answer. And so when we think about how to, thinking about computing healthcare spending or expenditures, the total expenditure for a service, so this is kind of basic accounting here, is going to be the price per unit times the quantity or the number of units. And so when we're working with traditional Medicare data, this is pretty straightforward. So the prices are set by the Centers for Medicare and Medicaid Services. And so, and actually they're like available well, they're actually in the claims data, but also they're available, on the CMS website. In contrast, the prices for Medicare Advantage plans are negotiated between the Medicare Advantage plans and the healthcare providers, and we don't see those in the encounter data, and so we really don't know what the actual price paid is. There's definitely some empirical evidence that the prices are lower in Medicare Advantage relative to fee-for-service Medicare. But generally, this measure of spending is not really something we can compute. So one approach for trying to come up with a measure of spending is you can try applying the publicly available fee-for-service prices to the healthcare use that we observe in the Medicare Advantage encounter data. And so essentially, if you can hold the prices constant at the fee-for-service levels, this essentially provides a method of weighting different types of utilization based on the intensity of care, which is measured by the fee-for-service prices. And this will allow us to answer the first two questions, sort of like what are the, if we assume that the price paid by fee-for-service Medicare is sort of a measure of cost, then we're allowed to say, like, how does resource use differ between Medicare Advantage and fee-for-service Medicare enrollees? Or how does resource use differ between different types of Medicare Advantage plans? it's essentially telling us if the providers were paid at the fee-for-service rates, the spending would be X. But this third question about total spending between Medicare Advantage and traditional Medicare, we just can't answer with the encounter data. So I just wanted to talk a little bit about how we might, use fee-for-service prices to come up with a comparison of resource use, between Medicare Advantage and fee-for-service or across Medicare Advantage plans. And so, the idea here is that we would have a price from fee-for-service Medicare, and we'd apply that price to healthcare use that we observe in Medicare Advantage. The key challenge here is that the unit of payment is in fee-for-service Medicare kind of varies across different types of services, and this just coincides with Medicare payment policy. So when Medicare is paying for hospital care, it's paying the unit of payment is a stay, right? So it's a price for a hospital stay. When Medicare is paying for care received in a skilled nursing facility, it's paying for each day spent in the skilled nursing facility. And when Medicare is paying for outpatient physician services, this payment is occurring at the service level. So each service has its own price. And so we have to take that into account when we're applying the fee-for-service prices to the claim. So we have to understand, what is the unit of service for that category of care. And then another kind of tricky thing is that the Medicare Advantage plans, have the flexibility to pay for services using different units. So for example, in the last segment, we talked about these fully capitated primary care organizations. So they're being paid at, the patient per month level. However, as we saw in that research example, we do see the individual services in the encounter data, even if they're being paid at a capitated level. So that is helpful. Another kind of tricky aspect of applying fee-for-service prices to Medicare Advantage healthcare use is that there are payment adjustments in fee-for-service Medicare, so that the same service may receive a different payment in different contexts. So the one important consideration is that the payments can differ based on the wage levels in a given area. So there are geographic adjustments where if someone is in Los Angeles, they would receive a provider in Los Angeles would receive a higher payment than a provider in perhaps a rural area in the Midwest. And so that's one adjustment. Facilities, hospitals that provide services to lower income individuals receive these disproportionate share payments. So a facility that provides those services may have a higher hospital payment than a facility that does not. And also there are differences in terms of hospital payments. The payment models differ for, say, a critical access hospital compared to an acute care hospital. And so that's another kind of important consideration. And so I think the key advice when you're applying fee-for-service prices to Medicare Advantage encounters is to kind of strip away all of those payment adjustments and just use kind of the base payment rate. And don't vary it by the facility, the geography or some of these other details, just to kind of hold prices constant and kind of abstract from those facility level factors. And so Jia Zhang and some of her work, I thought they did something that was a creative and a good idea, which is, one issue is that these adjustments are not budget neutral. And so the base rate, for example, for hospital care, you know, in the end, like the adjustments are actually on average positive. And so you might be using sort of an too low of a rate if you just use the base rate. So what Jia Zhang and her co-authors did is they applied an adjustment factor, which incorporated an average increase over the base fees. So when they assigned a fee-for-service price to, hospital care, for example, they inflated the base rate times the average adjustment across hospitals. So I think that was a good idea. So let's just talk a little bit about a couple of examples of how you might apply fee-for-service prices to Medicare Advantage healthcare use. And the first example is for hospital care. And so, as I mentioned earlier, in fee-for-service Medicare, their hospitals are paid a fixed rate for each hospital admission. And that base level of payment is determined by a base payment rate that is updated every year in the inpatient prospective payment system final rule. And then it's adjusted by the weight of a Medicare severity diagnosis related group. And so the idea here is like there's a base payment, and then if depending on the reason that someone is admitted to the hospital, that base payment is inflated up to a greater extent. And so, as an example, and this is actually not 2022, this is 2024. So a Medicare Advantage hospitalization in 2024 with the MSDRG 469, which is a joint replacement, you would take the base rate where there's a base operating rate in 2024 of $6,498, and there's a base capital rate which is $504, and you basically add those up and then multiply them by the specific weight of a joint replacement with DRG 469, and so the payment, the price you would assign to that Medicare Advantage joint replacement case would be $23,315. And so that's just an example of like how you could come up with a price for Medicare Advantage hospitalizations. Let's talk about a second example, which is for skilled nursing facility care. So as I mentioned earlier, fee-for-service Medicare pays a fixed rate for each day of a skilled nursing facility day. And so the base level of payment is based on this patient-driven payment model, which was adopted in 2019. And there are it's a bit of a complicated model. There's separate daily base rates for nursing and different types of therapy, and they're each adjusted for case mix. And so you can see the description of the skilled nursing facility patient-driven payment model on MedPAC has a wonderful set of documents called Payment Basics that describes every Medicare payment system. It's sort of I think it's geared to help Congress people and their staffers sort of understand some of the complexities of how the Medicare program works, but it's useful for research as well. And so, but one approach for creating a price for Medicare Advantage skilled nursing facility stays would just be to use the daily base rate for a skilled nursing facility stay times the number of days. So a 10-day stay, the daily rate in 2021 was $434.95. You multiply that by 10 days and you get you get sort of a approximate cost. You could also incorporate more information on case mix into that calculation if you had it in your data. But it's a little tricky here because if you just are using the encounter data, then you have limited information about some of the functional status information. So But I'd be happy to talk more about that. Okay. Um, let's talk about a third example, which is applying fee-for-service prices to physician visits. So generally, fee-for-service Medicare pays physicians based on the individual service. It's like a little more complicated than that because of the quality payment program. But let's sort of abstract from the quality payment program and just think about sort of the physician fee schedule. So essentially, the base level of payment for a given service is assigned based on the complexity of a service, which is given by the relative value units, patient acuity, and then the care setting for the visit. So is this occurring in an office, or is this occurring in a hospital outpatient department? And so, and you can see the payment rates for each HCPCS code. So that those are all the different types of services in the Medicare physician fee schedule. So if you see in the encounter data, the Medicare Advantage patient has an evaluation and management service with HCPCS code 99213, you could look that up in the Medicare physician fee schedule. The non-facility price is $92.05. So you could use that price, that fee-for-service price for this Medicare Advantage encounter. There are other, types of services that have their own kind of units of, the units that they're being provided. So for home health, Medicare is paying for 30-day episodes of care, and there are payments that are based on the home health resource group weight. So you could use those payments to price Medicare Advantage home health care. The hospital outpatient departments are paid based on the ambulatory payment classification fee schedule. And that's a unit of payment. Ambulatory surgery centers have their own fee schedule. Durable medical equipment and clinical laboratory services are a little more straightforward. So they're just paid per item or service using the HCPCS and with a fee schedule. But all of these payments, you could create a price for every type of healthcare use in Medicare Advantage using these fee-for-service data sources. So let's talk about other differences between fee-for-service data and encounter data. One tricky aspect of Medicare Advantage data is that, especially on the facility side, is that in the traditional Medicare data, you have a CMS certification number for every claim. So, for example, in MedPAR, every claim has a CCN, and that is a really useful identifier, right? It tells you sort of what type of provider that facility is, like, because the last 4 digits different ranges correspond to different provider types. Like, is this a short-term acute care hospital? Is this a skilled nursing facility? Is this an inpatient rehab facility? And so that's a really helpful way to categorize facilities. And that number is not present in the encounter data. You do have an organization in PI, and you can create a crosswalk from organization NPIs to a CCN, which is something we've done in the past. And so I think it's a little tricky to create that crosswalk. But the other thing is that you can use, I believe, the NPES to categorize. You can also map facility types to organization NPIs. It's just a little a little more involved than doing the mapping based on the CMS certification number. So one other, I think, point to raise is that, again, going back to the previous segment, there are cases in Medicare Advantage where physicians or institutional providers are not being paid per service; they're receiving a capitated payment, and I think the concern there is that, if again, going back to like the previous example, like if there is a primary care organization that is being paid on a capitated basis, like there's sort of less incentive for them to like report their encounters with the same level of accuracy. If they're being paid per encounter, then we think that that data is quite accurate. But if it's they're reporting it just for information purposes, there might be some more concern about that. I think that this is also an issue that may be coming up more in fee-for-service data as well. Although I think even in fee-for-service data, a lot of the bundle payment programs, like the the participants are being paid on a fee-for-service basis, and then there's sort of like a reconciliation that happens where the total spending is compared to sort of a target amount per patient, after the fact. And so it's a little bit different than like a purely capitated or prospective payment. So it's just something to think about. Okay, another key difference between Medicare Advantage data and traditional Medicare is this issue that you really have to focus on deduplicating the data before you start using it. So like in the fee-for-service data, it's like the final action claims. But in the encounter data, as shown in this kind of hypothetical example, like this same beneficiary on the same dates with like the same organization MPI has 3 records for the same service, and so you don't, and they're just these are just like replacement records, like the data is just updated, and you just need to, and as we discussed in the first example in the previous segment, when we were comparing HEDIS and encounter data, an initial step is just to deduplicate the data. But I mean, fortunately, it's not a too complex of a process. It's like, depending on what you're looking at, considering the beneficiary ID and the dates and potentially the service, and just dropping, just keeping one occurrence instead of, in this case, all 3. Yeah, so okay. And again, the other thing is, I think a tip, this is maybe not always the case, but often researchers drop the chart reviews, the chart review records. Okay, this is an interesting issue. So a key benefit of Medicare Advantage plans is that they cover services that are not provided under traditional Medicare, which can be things like hearing aids, vision services, dental services. It can be even like food delivery. There are many supplemental benefits, and especially like during the Trump administration, like there were some policies passed that really allowed them to provide even more supplemental benefits. But there are some concerns that these data aren't really showing up in encounter data. Like, it's really hard to see the actual provision of the supplemental benefits. And there was a policy that came out in the spring that like actually plans need to report this information, but it's still a little bit nebulous how they're supposed to do that. And I mean, some of these services may not even really have like a HCPCS code. So in any case, I think some of these services you can see in the data, but not all of them. So my sense is like stuff like telemedicine before the pandemic, like maybe you could see some of that type of service in the data, but it's not universal. And so just thinking about how you create analytic files between fee-for-service and encounter data, like many of the steps are similar. So you apply your demographic or geographic inclusion and exclusion criteria. You identify the target encounter records or claims records based on date or diagnosis or procedure or provider. You create variables, but then there are extra steps in encounter data. So like in encounter data, you want to make sure you remove the duplicate records, where in fee-for-service, you wouldn't have to worry about that, at least to the same extent. And, in terms of checking the file, good practice in fee-for-service is to review the enrollment denominator by month and year, review the variables you've created by month and year, and because there are some changes in procedure coding and occasionally even diagnosis coding, and there may be policy changes in fee-for-service or Medicare Advantage. But in the encounter data, there are additional kind of plan level issues that could come up, like what is being covered? Are they using chart reviews? You may, as we discussed, with the completeness information, like you may find that for certain contracts, like there might be some issues in terms of the completeness of the data. So there's kind of just these additional wrinkles about kind of data completeness and the just the variation in how plans work. So another consideration when you're working with these data is that you might be for some study, you might be following beneficiaries who are moving from fee-for-service to Medicare Advantage. And in fact, like this is actually a study design that you might be using, that I'm currently using and other researchers are currently using. You actually want to see how healthcare use changes when people switch to Medicare Advantage. And they're just like some kind of, you just have to think carefully as you're working on this. And like one issue is that, like if you're testing the effects of switching to Medicare Advantage on healthcare use, there's sort of this bias that if you're missing hospitalizations because the data are incomplete, that could lead you to conclude that, oh, like hospitalizations went down, but it could just be that the data aren't complete. And so how do you handle that? And so this question came up on the chat right when I was coming on before the last segment, like, do you use MedPAR or use the encounter data or do you use both? And actually what we've kind of moved to doing is, we use both. So you can test sensitivity to that, but it kind of depends on the question. But in our case, like given that there is this potential bias that kind of, there's this, you would hypothesize that Medicare Advantage is associated with like fewer hospitalizations. But then that could also be driven by due to capitation, but that could also just reflect data incompleteness. And so to a certain extent, it's better to be over complete with the data, use two data sources for the Medicare Advantage folks, just to make sure you're not missing hospital stays. So there are just considerations like that when you're looking at people switch between Medicare Advantage or from fee-for-service to Medicare Advantage. Another thing is that we've been working on lately is we've been trying to construct the comorbidity the chronic condition comorbidity algorithms going across, like these algorithms look across multiple years. And so you have to basically look for diagnoses in fee-for-service years and Medicare Advantage years, like in the encounter data and the claims data. And like that's kind of tricky. And so I think you just have to look at the raw files pretty carefully, when you're doing work like that. All right. So just to summarize, the Medicare Advantage data is really important. It's allowing us to study half of Medicare, which like otherwise would not be observable to researchers. But there are these challenges. It's not quite as standardized or complete as fee-for-service data. But I do think that it's a more and more accepted data source for studying this segment of Medicare, and I think we can learn a lot from it. And yeah, happy to take any questions anyone has.